Dr. DeAun Nelson, a naturopathic physician practicing in Portland, Oregon. I invite you to listen as I discuss how shifting the focus off of weight in healthcare can greatly improve health outcomes for people of all sizes. I will explore what it means to practice in a weight-inclusive paradigm and discuss tools to implement these ideas in practice. Keep in mind, the information I will present may be new to many of my listeners and may sound radical to some, but stick with me. This information could change lives. We are discussing weight loss surgery very frankly during the interview at one point. It's pretty early on. I think we're pretty much done with it by about minute 30, 35. It's kind of hard to be precise because I'm doing the intro right now. So you can skip that part. I think we start talking about it around minute 15 to 20 after Fiona talks about her life. But we are discussing weight loss surgery, how it works, how it affects health and nutrition, how it intersects with weight stigma and medicine. So if that is going to be triggering for you or upsetting for you, I would urge you to either not listen to it or know it's coming and be able to take care of yourself. Also in the episode, I mention a woman who directly attributed fat bias as a significant contributor to her death. I didn't remember her name at the time, and so I did look it up, and her name was Ellen Maud Bennett, and she died in 2018. Now I'd like to introduce Fiona. Fiona's mission is to empower health professionals to adopt weight-neutral practice by providing support and training in how and why to do so. In short, she wants to destroy the perception and practice of dietitian as food police. As an advanced accredited practicing dietitian and university lecturer in nutrition and dietetics, she values nourishment, autonomy, authenticity, and evidence-based practice. Her academic research areas are dietetic private practice benchmarking, interprofessional learning, and health at every size integration into dietetics. A love for research and presenting has led her into presenting professional development workshops for health at every size integration into clinic practice since 2013. Fiona has close to a decade of academic work under her belt as well. She has also reviewed submissions for peer-reviewed academic journals, including Appetite and Fat Studies Journal. After graduating from dietetics, Fiona spent 3 years as a clinical dietitian and then built a successful practice before selling it in 2014. Much of her private practice work was with chronic dieters with whom she frequently used the non-diet approach. She has also been working on a PhD, and her research findings have cemented her resolve that weight-neutral approaches should be a part of every clinician's skill set, and her research continues to inform the professional development workshops and trainings she provides through Health Not Diets. She will hopefully be finishing her PhD in 2021, and we look forward to having another amazing professional in our field. She's the author of 2 non-diet approach guidebooks for health professionals and developed the non-diet approach model, which operationalizes the health at every size principles for clinical practice. Fiona has great enthusiasm for demolishing weight-based research and overusing food and eating metaphors in everyday life. She is also the creator of the Unpacking Weight Science podcast. I recommend checking that out for sure, and even joining the Patreon so that you can get all the episodes. Without further ado, here is Fiona Willer. Okay, so I am here with Fiona Willer, who is a registered dietitian in Australia and also a PhD candidate, and she can tell you more specifically what that's about. Welcome to the podcast, Fiona. I'm so excited to have you here.
Thank you. Thank you very much for having me.
Yeah, this is going to be really exciting, I think.
Yes.
The reason I wanted to have you on was because you do this amazing podcast called Unpacking Weight Science, and I've listened to the first 5 episodes, and they're so good. So good.
Oh, thanks.
And I wanted people to be able to hear you, in a different venue, or if they haven't found Unpacking Weight Science, maybe this will be an opportunity for them to go check it out. I know you have way more than 5 episodes, and you have an amazing Patreon, but
people can start out with those first 5. And so what I wanted to do now is just like have you tell us a little bit about yourself and how you got into dietetics, how you got into health at every size, and then of course into research, which is very exciting.
Well, it is a long and windy road, I guess. I was a dietitian later on in life, although 24, that's not really later on, but it was my second degree. Yeah.
That's early.
It felt, I was a mature age student at the time. I felt very elderly compared with the other students. But anyway, so the reason I came into dietetics was that essentially I had had an eating disorder forever. And I wanted to sort of fix it. That was the main motivation for getting into dietetics. And of course I wanted to fix everyone else at the same time because...
Like you did.
Yeah. And I finally started getting treatment for the eating disorder towards the end of my degree, after someone had handed me a copy of a book called If Not Dieting, Then What? By Dr. Rick Kausman, who is an amazing man and one of the leaders of the movement in Australia. And so a more senior dietetic student had handed that to me and said, you need to do this. And I said, okay, and I did. And then, you know, the gears started shifting. Then when I graduated, I went into hospital dietetics, and then I got asked to come back and tutor at my alma mater in dietetic subjects, and I bought a private practice all in the first year whilst also getting treatment still. It was a lot, but I'm the kind of person who likes to do lots of things, and I still have a problem with saying no to things. So it's part of that. And you can't really be in academic circles, particularly tutoring and doing the sort of teaching work of academia, without you first of all can't go up the ladder without getting a postdoctorate degree, postgraduate degree, and you continually get hassled. When are you going to do your PhD? When are you going to do it? You're really good at teaching. We want you here. I can't employ you permanently until you have a PhD. When are you going to get a PhD? It's constantly, yeah, yeah. And I put it off for a few years, by which time I had 4 or 5 years in private practice and seen for myself people who were literally had gone through the same sort of things as I had. And I had also, at that point, I was what's called a fence sitter. I was sometimes doing non-diet approachy things and sometimes doing weight loss stuff, depending on the client, but not in a terribly nuanced way, I don't think, like looking back, because back then, this is sort of 10, 11 years ago, it wasn't really clear in dietetics in Australia. It wasn't a clear practice area at that point that people sort of talked about in a kind of boundaried way. And anyway, so PhD, yes, okay, yes, I'll finally do it. I will do it. And I'm going to do it in this because I want to know how I should be practicing. And I want the time to spend to properly investigate where the role of health at every size is in dietetics. So that was sort of my motivation there. And that was like 8 years ago. I'm still doing the PhD.
They take a while. I do,
and I'm doing it part-time, and I keep having babies, and I'm not having any more babies. The final baby, the PhD, it's born, it's done, family's complete. The topic is still the suitability of health at every size and health at every size informed approaches in dietetic practice, and sort of the feasibility and the impact on eating behaviour, including diet quality. And what I mean by that is basically the variety of foods that people eat, and on eating behaviour, so sort of restrained, non-restrained, extreme weight control behaviours, those sorts of things. So what happens when we take a weight neutral, size acceptance, body liberation type approach versus traditional weight-centric dietetic practice? Yeah, so I mean, these days I don't do private practice. I had to sell it when I moved to where I live now, and also not working in a hospital anymore. But those hospital years did give me a good insight into the long-term effects of weight loss surgery as well. So having to keep patients alive who had previously, decades prior, had weight loss surgery and were now subsequently dying of something else, you know, that's why they were in, and having to keep them, well, having to desperately try to keep them nourished while they were going through those things. So that has also informed my perspective.
Let's go into that. We talked a little bit before we started recording, but that's a great segue about the sort of like nutritionally what happens and physically what happens when somebody has weight loss surgery, because that has really started to be touted as, you know, like the gold standard for weight loss. And that's, you know, if you're of a certain size, then you should, and the certain size is getting smaller and smaller, unfortunately, but that you should have that done, and it cures all these ailments, which it doesn't really, but
Yeah.
So yeah, I mean, I would love to talk about that and kind of find out, since you've actually been in the trenches, so to speak, and being able to work with people who have had it. Yeah.
That's it. I mean, it's terrifying. What we're doing with somebody is introducing a new nutrition threat into their life. So when people are doing intentional weight loss dieting, behavioral weight loss, it's a short-term behavioral thing. And of course, there are some long-term implications at times if the malnutrition has been for an extended period of time. But for people who are basically dieting, losing a bit of weight, and then regaining it as bodies do, the long-term consequences of that are mostly psychological, with a little bit of physical stuff going on. Certainly there's loss of sort of muscle condition and stuff a long time. But in terms of things that will kill you, that is not a huge effect of intentional weight loss efforts until you get tired of it. With something like weight loss surgery, what we're doing is introducing something that actively encourages malnutrition in an individual. So it's no longer about chronic disease risk, because that's a numbers population game. It is about introducing certain malnutrition into that person. And so that makes me mental from a epidemiology perspective. That's really not how population risk goes. You can't compare someone who was larger and is now malnourished and a smaller body weight with someone who's been an effortlessly smaller body weight through their life. They're very different. Yeah. It's completely invalid to say that that's a fair comparison, you know?
Agreed.
So there's that factor, and the malnutrition, it depends on the different type of surgery that you have.
Right.
And it also depends on, of course, your eating habits after the surgery. Surgery doesn't do anything to affect the quality of the diet that somebody has. Again, when I say quality, I mean really variety is what I mean, except to limit the intake of some foods that cause discomfort depending on the type of surgery.
Right.
And of course, it doesn't do anything up here except encourage starvation-based issues with cognition. You know, we know that if we starve someone, that we can make them obsessed about food.
Right.
And we can make them hyper aware of stuff. It's not a good place to be mentally. So it doesn't affect, you know, the conflation of healthy eating patterns with a smaller body weight. That's invalid when there are so many people in so many different sizes that has no bearing on the type of food that they eat.
Right.
Again, all of that detail comes out at the population level, but at an individual level, you can't tell what someone eats or how varied their diet is based on essentially their appearance, which is what weight kind of is.
Exactly. The only thing you can tell is what they look like.
Right. Otherwise, you know, if you could tell, like, okay, well then there's no reason to do any more diagnostic testing. We'll just eyeball everyone and that'll be enough.
Exactly.
It's actually absurd.
Right. And if you're psychic, why are you in medicine? You could be making so much more money doing something else. I mean, really.
Yeah, right, exactly. And so malnutrition itself comes with a lot of health risks. And if you are lucky to survive that malnutrition for a long time, you will be osteoporotic, bones crumbling everywhere into your elderly years. Plus, people get more unwell as they get older. So the risk of chronic disease that we worry about is mostly affected by age.
Right.
So those things are all rolling along in the background for people who've had weight loss surgery as well. And then we have to try to help people that are always nutritionally compromised because of the surgeries that they've had, to try to overcome and manage these conditions that they now have, the things that they were trying to avoid, because age is really the biggest predictor.
Well, and there was something else that I was wondering about too with aging, because, and this is a little bit old, so I don't know if it's still applicable, but when I was reading about it recently, a while back, that a lot of the surgeries that they do don't actually have, because they change it slightly pretty regularly, there aren't really long-term studies on, the newest surgeries.
Oh yeah, so sleep.
The long-term results that we have are from surgeries that they're not doing anymore necessarily.
Yes. And it depends on where you live as well, globally, because there are fads that come in. The surgeons who do these things are affected by what they feel like is new in the field, and so I remember when I started out as a dietitian, gastric banding was the thing, and the surgeons would brag about how many they could do in a row in the morning, and this is in the hospital. And I just, yeah, right. So, and now bands are definitely uncool, if you want to put it, to put it that way. Sleeves
I actually know several people are trying to get theirs removed, so.
Yeah, lots of people are, because thankfully with a band, it's an appliance that has not required actual removal of any gastrointestinal tract. It's a physical barrier rather than actual surgery that's gone into the guts, if you understand it that way. So yeah, loads of people are getting them out. They're just, accessories that you can't see. So, but these days it's the gastric sleeve. And so if listeners aren't aware, that's where they take your stomach, which is a bit like a bagpipe shape, and they make it into a tube. And usually stomachs are incredibly muscular. Their job is to grind and mush that food until it is soup. So you put it in chunks, like when you eat, we don't chew nearly as much as we think we chew. No. Anyone who's ever spewed up after a meal knows how much we don't chew, right?
Yes.
The stomach's job is to make it into slow cooked soup by the time it enters into the intestines. And
something that I remember in anatomy and physiology when we learned about how the stomach works, and this is something that always got me when they would talk about removing parts of the stomach, was that there are actually 3 different
directions of muscle.
Yeah. So it basically is like scrunching all these 3 different ways to get the food, like you said, to a point where it's just mush and almost liquid and going into the rest of the body. And that's so whenever I think about that, I'm like, well, what is happening to the food? Like, it's just not, is it like whole food going into the intestines?
No. So what happens? So usually stomachs are usually like an industrial mix master, right? They are insanely good at the job that they have to do. Make it into soup before it goes into the intestines, and it has to be soupy. Yeah. It has to be soupy because that means that the bits, all of the soup is exposed to those receptors that want to grab out the nutrients in the stomach, in the intestines there. And that's the first few feet of the small intestine after the stomach are that's a magic mile of nourishment there.
Which is awesome that is removed in the bypass too, or parts of it.
That's it. Because nourishment is set aside for starvation in those surgeries. Right. In a gastric sleeve surgery, they leave the intestines alone, but they make the stomach into a tube. And what that does is completely disable the ability of the stomach to have any grinding potential. So I've just recently read that literature about muscle potential in stomachs after sleeve surgeries. It's dormant. The stomach does not move anymore. It is like a tube that works on gravity alone now. In the bottom of it, towards where the lower bend used to be, there's some like cilia that beat. So there's a little bit of residual sort of folds beating, but there's no muscular grinding action anymore. And that just makes me want to cry. I mean, it's terrible. The stomach is amazing, and it does not work as intended anymore.
Right. So what I'm thinking is, I mean, if you think about that, and then you have, I mean, if you're not literally chewing your food to soup in your mouth, it's not, I mean, you've got fairly solid food going into the intestines.
Yeah, so that won't necessarily do damage to the intestines because they're quite flexy, but it means that we can't absorb.
Right, because the surface area is larger.
Yeah. And the purpose of the grinding is to mix it's to make everything smaller and wet, but also there are lots of protein denaturing components, enzymes that are being smooshed around with the proteins that you've eaten to break them down. And so you end up with a situation where you're not as able to absorb the amino acids from the proteins that you eat because they haven't been broken into amino acids in the stomach. That function is limited, not completely gone, but limited. And then you've got of course, if you've got a chunk of food at the little tiny receptors in your stomach, in your intestines are not going to be able to get into that.
Right. They're gonna be like, what is this? I don't know. Keep pushing it along.
Yeah. So its only chance to get get its golden ticket into the body is to wait until it reaches the large intestine, gets fermented to an extent by the bacteria in there. That will break it down a little bit. But again, they're not terribly, the muscles in the large intestine just go from one end to the other to push things along. They're not there to really squeeze and moosh. So yeah, I mean, it is a surgery.
They don't have hydrochloric acid either, and
no
enzymes that break down.
That's it. You're sort of waiting for the opportunistic bacterial colonies that can feed off what they're given to get into it. That's really the only opportunity once it's in the large bowel.
Yeah.
But so really the surgery is designed to make you feel full faster because there's less physical capacity in there, fills up more quickly, and also to reduce the amount of potential nourishment that you can get in. What happens over time is that, because we see it in gallbladders that have been taken out, people do develop sometimes a little pouch that's like a little surrogate gallbladder there to catch the bile coming out of the liver. And then they have, potentially have issues with that. Tissue stretches. Anyone with a body knows that tissue stretches, and stomach tissue is not any different from that. And so over time, that tube becomes larger than it was during the surgery, except now it's also not got any function. So we'll end up with a situation where people have gastroparesis.
Right.
Which, like when the stomach is a tube, there is gravity, maybe it works all right. But when it's a larger bag and its weight, it's like a big sink with a tiny plug hole in the bottom waiting for the food to go down. It's not going to function properly.
No.
That's hideous.
That is hideous.
So, yeah, I mean, this is not...
I've thought about it, but I haven't thought about it in this much detail, and that, yeah.
For someone who values nourishment, like dietitians, health professionals should value nourishment, right? It goes completely against our values, this surgery. So, and thinking then to the long game, because you cannot forget that long game, particularly now that they're doing gastric sleeve surgery, particularly in Saudi Arabia wants to make a name for themselves doing gastric sleeves in toddlers. And so that there is like a race to the bottom. Yeah.
Oh my God.
It's heartbreaking. You can't really read these papers without crying. Honestly, it's awful. These very, very young people who are, this is supposedly done for their own welfare, right? To make it to old age. And yet the plumbing that they're left with is unlikely to be able to help them to get through the other things that life's going to throw at them through the next 70, 80 years.
But if you even make it that long.
Right, exactly.
If you've got a starving toddler, you know, I mean, we talk about failure to thrive, you know,
Yeah, let's induce it.
and yeah, and we worry about that so much, and we try to make
Yep.
sure that they gain weight and, you know, are healthy. And then basically starving them. I mean, how do you expect them to survive past childhood? Honestly, I mean, I don't know if there's long-term
No,
on those kids yet, but
no, in those 2-year-olds, so that's within the last 10 years that those surgeries have, it's like come up with the gastric sleeve.
are they still alive? The kids who've had them?
I believe that they are, but again, I mean, the papers make for hideous reading because they're case studies. They're not randomized controlled trials, thankfully. They're case studies, but that means that you get a lot more detail about that individual that's had the surgery and the individual's family. And reading it, I guess, reading it as a Westerner and someone who's quite viciously left-leaning, you can't help but see, you know, these are from lower income families, marginalized even in Saudi, who are, you know, the surgeons are giving them the surgery for free, but then no lifelong follow-up care, and the whole thing is just patently unethical.
They're just practicing doing test cases.
Yeah, and the glee that the authors of the paper have about how cutting edge they are doing it in these cases is just disgusting.
Agreed.
Mm.
I'm gonna go cry now.
Oh, sorry. I mean, it is desperately awful. So, what the consequences of this movement towards sleeves and gastric bypass? I mean, gastric bypass has been around for a long time, but what we're going to experience if we've still got this push for people to have these surgeries is a whole heap of people going into their later years and experiencing the normal things that occur to people in their later years, and having to get very creative with being able to nourish people. And so we're going to need, as a dietitian, we're going to need our workforce up to speed with all of those methods because the wave is coming, you know?
Yeah. Oh my goodness. Have you done some research on the various bypass options that people are doing?
So as you mentioned before, they do change them, and it depends on, like, it literally depends on what bits of guts present themselves to the surgeons in the surgery, like where
they don't specifically take out sections, they just kind of whatever shows up.
No, they do take out around the anatomical landmarks. But it's not like they go 1 meter or like 2 feet or whatever. It's like, yep, okay. Like it's not measured.
Right.
Does that make sense? Right, people's guts do not come in, you know, you can't tell really how
they don't
long
come in the different colors, like on the
no. And you can't, I mean, you can tell, you go like, right, stomach, okay, there we go, right. So that's the bit I'm going to take out. But the actual length that's taken out compared with the actual physical length of the guts that the person has, because that varies hugely between individuals as well. So we've got a lot of variation. It's not like it's not a standardized surgery, is what I'm trying to say, is that there's so many different factors that are at play when those bypass surgery, particularly those types of surgeries happen, that we can kind of predict in general terms what somebody's outcome might be like. But at the actual individual level, you just have to take as it comes, because that person may have had longer magic mile intestine than the person before them, you know. So we really, when it comes to nutritional deficiencies, it is likely, but we really have to take that person individually. You can't, there's no guarantees. And as you said before, some people think it's fantastic and have had it. But of course,
and they don't seem to have as many problems. So is that a result of anatomical differences, basically?
Oh, look, it could be. But again, like, not everyone fronting up for this surgery is created equally either. So you've got some people who are actively malnourished at the point of surgery, and others for whom, like, they haven't had a huge history of weight loss dieting prior to it. They're sort of more diet naive, I guess, starvation naive. And so they may have different outcomes. We simply don't know from the kind of data that's collected about people prior to the surgery what is predictive of better or poorer outcomes. And look ahead, you know, the diabetes weight loss study has shown us that we can do all these things and it still makes no difference to cardiovascular death. And that's kind of the reason we were doing it, wasn't it? Unless the reason is actually fat phobia, you know?
Or, yeah, maybe that's it.
So it is ridiculous to use body weight and also to use biochem risk factors for long-term prediction without actually following people in the long term. There's this huge, like, the bridge is not built. We've got the pylons at one end and the pylons at the other end, which is death, and we're assuming we know where the bridge is. But people are falling in the middle because we really haven't connected the two dots together properly in the evidence base yet.
Right. And I often wonder, and maybe you can speak to this, I don't know, when, like, number one, if somebody has bariatric surgery, regardless of what it is, and then they die at some point well after the surgery, right? So, like, not because of the surgery or immediately after, but something that maybe is not directly associated, but they're not their death may or may not be blamed on complications from the surgery if it's far, even if potentially it is, because, you know, they're starving or their body's not responding well. So, you know, I wonder how much we lose as far as information goes, and knowledge about that. And then on another part that I often think about is people who are in large bodies who, when they die, regardless of the reason they die, it is attributed to their large body.
Oh, yeah. And
their disease is attributed to their large body, which, you know, brings in the whole fat-centric way of looking at things, or the weight-centric.
Because larger people are not permitted to have bad luck.
Exactly. So, so then we have, you know, officially all of this stuff that's blamed on people's sizes, where, you know, where maybe that's not actually what was going on. They just happened to be in a larger body, where if they were in a smaller body, that their death would be blamed on, or would be attributed to something different.
That's it. I call that Schrodinger's fat, where somebody simultaneously, all the diseases are from the fat, and yet fat is the only disease.
Right. That's amazing. There was recently a woman who, I don't remember her name, and I apologize to her family, but who died in the last few months, I think, and she specifically put in her, she knew she was going to die, and she specifically put in her
obituary that eulogy thing.
That fat phobia killed her.
Yes.
Because she didn't get the care that she needed initially. And so, you know, I'm like, wow, I wonder if we started having people recognize that and then call it, and then say why they actually died, like physically died. But so then you could say that they are dying because they're fat, but not because of the extra weight that they're, or the weight that they're carrying, extra, but because they weren't being cared for, and they didn't have access to the care that they needed.
Yes.
Which is very different than
it is. And I talk to
have a certain amount of fat on you.
That's it. I talk to doctors about this all the time. I'm like, this is a massive flag for missed diagnosis. That is what you're doing. When you are saying that you can assess somebody's entire life by looking at them, you are going to miss very deathy things in that person, and it will be your fault.
Right.
You need to look deeper, look past appearance into the actual things that you look for in smaller bodied people, please.
Right.
So it is quite sobering when people realize that, you know, lift the veil and they realize that they don't actually know everything that they thought that they did know, you know, because that assumption that the way that we eat is reflected accurately by our body size is one that even dietitians have. And the data is really clear. And again, if that wasn't, if that actually was the case, there'd be no reason for us to have to like take a diet history or be really anally retentive about calorie, like, you know, and nutrient intake. And we would just know, right? We'd be able to assess dietary intake and calorie intake via someone's weight. That's not how it is. So that like, all these signs are there. And when we look, if you take someone's diet history, their usual eating pattern, even if it is as scientifically accurate as you can get it, and there are so many margins of error in there, but let's say that it is as, you know, as good as we can get it at the moment, you still can't predict their body size from that. They're two completely disconnected concepts, except like at a population level, when you've got thousands of people that you're looking at this data in. At the granular individual level, it's completely non-predictive. Right. So that misunderstanding about the connection between eating habits and physical activity habits and body size is really what is continuing to push us down this fat phobia path, because it's just assumed to be a choice, assumed to be lifestyle choices. And that drives me crazy, because there are so many signs in the literature that is not the case. We're willfully ignorant of that.
Yes. It is, yeah. And I feel like all of us have at least one course in the beginning in our training where we talk about correlation versus causation, and then it's like everyone forgets that they're not the same thing.
And it's not even
goes about, you know, saying, oh, well, this is the cause. It's like, no.
And the other thing, that correlation, causation, yes, statistically we need to know that. More people need to really, really know it.
Right.
But also that difference between generalization, so correlational data is going to be group stats. Right. Because that's the only way you can make it statistically significant, is to do it with a lot of people, right? That means that it isn't valid to extrapolate that to an individual, because it is by definition a group statistic. And so that sort of recognizing what uncertainty is built into those correlational statistics is really important. It's where like guidelines are interesting, but sort of a bit like birth plans, right? They're good to have, they mean nothing in real life, right? The actual minute-to-minute function of somebody's experience has nothing to do with the guidelines or the birth plan. Exactly. So that I wish more people understood that, you know, that their life is really about a series of huge uncertainties rather than a transactional do this and you'll get that outcome. It's not, you know, capitalism doesn't work in bodies. It's not how the things go.
Right. And what I guess what I'm always have a hard time understanding is why we're so stuck on the weight. Like, why are we so stuck on it? Because we are, even if you don't even look at research, just anecdotally, right? You can look at the people that you know, yourself, and you can see that there are people who, you know, eat everything under the sun and they don't exercise and they, you know, don't really take care of themselves necessarily, and they're thin. And you can see people who, you know, who are doing, you know, taking care of themselves and eating healthily about a variety of things, you know, exercising, all that, and they're larger, and then vice versa. And so I just keep thinking, like, as a doctor, I mean, we want to look at statistics. So if you look at statistics, you go, oh, hey, look, you can't tell somebody's health by the size of their body. You look at anecdotally, which I know we're not encouraged to, but it really does help. And then you can say, oh, hey, you can't tell somebody's health by the size of their body. And then it seems like a lot of people just throw those two things out the window and say, I can tell everything about somebody by the size of their body. And I understand weight stigma is a thing. I think you actually did also a podcast episode on it, as did I. I talk about it a lot. But like, have you discovered anything that like kind of points to why we are so, why that's become such a focus?
I think again, it's that the assumption that the lifestyle is expressed in the body shape, because our national guidelines and all of the like Chicken Little, skies falling in, epidemic stuff points to, oh, well, weight is modifiable. Weight is just a lifestyle choice. And so that's how it is sort of materially different in terms of stigma terms from something like skin color. So that's the back door. That's the escape hatch for people who are trying to justify their discriminatory and stigmatizing attitudes towards people in larger bodies. It's that perception that it's modifiable. If we could get that removed, that would be great. That would decrease the stigma significantly. And you've got to think about the sort of people who are making these recommendations are not typically people who have the kind of bodies that they're making the recommendations for. And I think that assumption of the way you eat and move is reflected in your body, that assumption, because people in smaller bodies don't eat that well either. Because if you look at the guidelines, and I'm not saying that they're great, because there's a lot of issues with trying to impress exterior, non-culturally sensitive dietary guidelines on a population. But if you use those kind of assessment methods, about 90% of the people in any given population are not meeting food-based dietary guidelines anyway, regardless of what kind of bodies they have. And so I think it's that the people who have these positions of power eat they eat the way that they eat. But they assume that people with larger bodies than theirs are eating exponentially towards the not great side of dietary pattern side of things, because that's how they've been told. If my body must be okay because it's smaller and I eat this way, therefore larger body people must eat much worse, in inverted commas, if you see what I mean. Yes. And so from there comes like the cascade of moralization and medicalization and all the things, that perpetuate stigma. That still belief, that connection between lifestyle and body size. Every time when I read the research and my original research as well, that connection is so pervasive in the community and even in health professionals.
Mm-hmm. Yeah.
And education's not the key, but it is one of the pieces.
It is definitely
of the puzzle.
One of the pieces.
Yeah, so we have to get the message out, but also promote people in diverse body sizes into positions of power so that they can call out the BS themselves in a power hierarchy.
Exactly. And stop making the assumptions that we know what's going on, or that people who are in naturally slimmer bodies doing what they do will actually change anybody else's body and make it look like theirs. Because that's another thing that I see a lot too, where people are like, look at me, I do all this, I do all this stuff and I'm thin, but genetically they might also be thin even if they were,
there's no doubt, because we know how much diets don't work.
Mm-hmm.
People's bodies are likely to be, if they don't diet too much, they're likely to be what they would have been whether they're eating one way or the other. You know what I mean? It's so genetically predetermined. So if somebody is eating, vaguely to their appetite cues and not very restrictively, their body is their body, and it would have been that way whether they're on any types of fad eating plans or whatever. Mm-hmm. Because we know that weight regain happens in virtually everyone. And so our population stats are they're not that affected by dieting, because dieting isn't that effective at doing anything to body weight.
Well, except for it does seem to increase it.
Yes, so we've got it bumps us up. Over time, populations tend to gain weight with age, because that's how bodies work. And so it is how bodies worked when they were doing the height and weight tables back in the 40s and 50s. That's how bodies worked then. If you look at all the different risk, they used to age group it. It's much more accurate to age group it. And the BMI would go up with the as mortality rate went down as people aged. But thanks to Ansel Keys and George Bray, no, one number is easier for the population, so stuff them, you know. It's not reflected in actual human experience.
Right. And I've often wondered with our history, with our well, at least like in the United States and Australia, Canada, and Western Europe specifically, I'm thinking about, we have had like a lot, and then when you see a lot of the people going into other countries bringing this like body dysmorphia and diet ideas into other countries, we start seeing similar issues in countries that didn't necessarily have those problems before. And so I think back, and because we talk about, like the weight gain between the 80s and 1980 and 2000, population wise.
Yeah.
And I've often wondered, because we started doing more restrictive dieting, like very intentionally, not just like, oh, there's not enough food right now, and then we eat, and then when we don't have it, we do what we can. But then there's like, the more intentional of restrictive dieting that I suspect has, led a lot of people into the binge restrict cycle in much more of a way than we would naturally do if we had minor fasting times.
Yeah.
And so I wonder, like, I've always wondered about if anybody has found a correlation between that and then like the population weight gain, or they're maybe not related at all. I don't know.
Well, I agree. I think it's going to be in there somewhere. But if you have a look at the population stats and you have a look at the segments of the population who are doing the dieting and the weight regaining, so that's disproportionately female. A weight gain in the population is disproportionately male. And so there's going to be some dieting related weight gain in those population stats somewhere. But I don't think it's the whole story either. And, when people try to find, the one story to rule the whole thing, I understand now.
That's what we all want.
Link. That doesn't exist in epidemiology. The whole thing's a freaking mess. Like, we are so complicated, and the world that we live in is so complicated. You can't be an epidemiologist without being massively optimistic, because it's so messy.
I love it. So, I think I might quote that part. You can't epidemiologist without being optimistic. I like
it just, because you would go mad with the horror of uncertainty and mess that the world experiences. So yeah, I think it probably is in there, but I don't know to what extent. There was one mortality study that I was looking at that, their brief for the research that they were doing, they took a national data set. I wish I could remember, it might have been US, but anyway, national data set to try to figure out really what mortality risk and BMI is. What is it? Let's really find out the differences. And they got so annoyed that people who had intentionally lost weight into a lower BMI band were messing up their statistics, because they were pulling up the mortality rate of the lower BMI band, even sort of 15 years out, that they pulled them out of the analysis because they were annoyed that they were muddying the data. And I'm reading this paper going, are you serious?
We need to know that information.
Oh, well, they presented how much, but the justification, will take it out because we want to know the true one. And I'm like, yes, but you're going to use your research here to justify why people should not gain weight. Like, it's disconnect. That's not a valid method to find that.
Well, see, I wonder if you did, like, you had sort of a study where you had all of the people, everybody in it was at the weight that they were at, and they hadn't lost or gained,
stable weight.
Although I'm sure for the higher weights, it would be much harder to find people who had been at that weight their whole life and not weight cycled. But So like to do something more like that, where you're like, okay, like this is where people naturally fall, and then do mortality and morbidity,
yeah, without the weight cycling in there.
And then take all the people who have shifted up and down in the BMI or are artificially in a BMI their body doesn't necessarily want to be in, which can be higher or lower too, because like some people have excess weight that their body's like, well, if we start doing stuff, this will go away because I don't really need it. And then of course people who like artificially keep their weight low, and then you could have like a separate study. But man, that would be so messy and really hard to find people.
Well, there is a study out of the UK which looks a bit at intentional weight loss and mortality, and there is some of that in there. I'm just trying to, I can't remember the name of the author, but I can pull it up. I can send it to you for the show notes if you have that kind of thing. But it does, like more than any study that I've seen recently, does try to unpick that. But of course, then like studies that do that, they then get into a very uncomfortable position where they have to say, well, this looks like dieting is not that good for people. That's uncomfortable. Because the politicians are telling me that dieting is what we need to tell the people to do. So, yeah, it's difficult to get that stuff published. I mean, I found with my work, it is difficult to get, because mine's very dietitian-y niche research that I've been submitting for publication so far. And the amount of ignorance from the reviewers, like, I don't want to have to get you from zero to hero about Haze in order for you to read the paper.
Right.
I want you to know what you're talking, know this stuff first, and then, be able to assess the paper on its own merits and the research on its own merits.
Is there anybody that you can have to peer review your stuff? I mean,
yeah, there are, but of course I know them a lot. And so if you can't, it's supposed to be blind, and it is fairly blind, but if people, and because we're a relatively smallish research field, you kind of know who's doing this kind of research in that location. So the paper, even though the author's names aren't there and you've sort of redacted if you've cited yourself, you've redacted that as well. And you've redacted the institution name, but you kind of know who these people are.
This sounds so much like Fiona.
Right. And so if they know who you are, you're not, if you know, like if as a reviewer, if I know who the authors are, I'm not supposed to review their paper because that's not really proper blind peer review.
Right. Can you tell in other countries, or do you also know everybody generally in other countries as well?
I do, unfortunately. Yeah. Yes.
Doing English.
That's it. Plus my research that I've been submitting recently it's a very Australian context. But so it's easy to get it into Australian journals, and it's more appropriate for Australian journals, but it's a very small world down here. And in terms of particularly Haze research, like there's very few full-on Haze researchers down here. And so I send them internationally, but then of course you start getting, it's a bit less relevant for the journal if it's Australian data. Right. So yeah, it's tricky, but
I'm so glad you're doing it though. It's important.
It needs to get out there. I have a fire in my belly. It's got to get out there. But there are all these sort of things that in a regular kind of non-controversial research area, these things would not be very difficult to publish. But we have to, I mean, this is a story of like women, isn't it? That we have to try, 1,000% harder, be 1,000% better to just get to the same playing field.
Yeah.
So, yeah, joys. But anyway, I will continue to do it. It has to be done.
I'm so glad. I mean, I really do recommend everybody to check out your podcast. It's amazing.
Thanks.
And so helpful. I'm trying to think, like we're getting close to kind of time, and I know you have an appointment coming up at some point soon. So I was just looking at my little list of things that I would really love to talk about. Like I said earlier, I think that you could probably come back if you wanted to.
Oh yeah, whenever.
We can talk about other things. But I was kind of looking at the, I don't know if we can combine these, the theoretical versus actual weight change and the type 2 diabetes and weight loss, the 5% weight loss.
Yeah.
Because they seem to me like they would kind of work together.
Yeah, I can dovetail them, for sure.
Like, you know, we're being told a lot of the time, you know, that if people would just lose 5% of their body weight, which I often remind people is such a small amount of weight, like, and it had started out, I think, 20 years ago or so, it was like 20% of your body weight, and now it's 5 or less. And if you think about that, you know, I mean, yeah, it's very small if you start doing percentages. Even at a very high weight, like, it's still not really that much.
Yeah.
And like,
the thing about,
go on. You keep going.
The thing about the 5% is that is not that they have made the participants in those studies lose 5% on the nail. So the when they go into the study, their weight loss goal is not 5%. When they go into the study, the weight loss goal is whatever the hell you can manage for the study team. Everything that you can. Do all the things. This is as much weight loss as you can get off. Just get it off. We need it off you. Right.
And so we don't care how? Do they not care how? Or?
Well, they want you to do their program, but they're all virtually the same in terms of, you know, you can't really get a research program up, funded, or ethically through that is completely ridiculous. Well, I mean, from a weight neutral perspective, lots of them are insane, but they usually have a physical activity component, and they usually have to include fruit and veg. You know, like there are things in science research, scientific research, where you won't get, like, it's not the Beyonce cayenne pepper frickin' whatever that thing that she was doing a few years ago. That's not in the literature because that wouldn't get through. Fasting does. There are so many problems. But anyway, so if we take these studies that are, let's say, for the diabetes management ones, the people in there are told, do our plan, lose as much weight as you can. And they're quite open, like in something like the Look Ahead trial, which was it ended up being 9 to 12 year follow-up for people. They said your personal weight loss goal is at least 10%, because they wanted the whole cohort to be at least 7%. They knew, like, it's built in, the researchers know that there's going to be variation in people's weight loss outcomes. And so you've got in those weight loss trials, people trying really hard. When you get their 6-month, 12-month, 18-month data, it's always a kind of like diagonal line on a waterfall plot, where you've got some, what I call super responders, or the statistical unicorns, the ones who respond to whatever program they're on for whatever reason at that particular time in their life. Their body was capable, willing, able to lose a ton of weight at that time. And then you've got people, you know, and that is not most people's experience. It's maybe 5% of the entire cohort in the study that's really lost quite a bit of weight. And they're also the ones that get wheeled out onto, or rolled out into the media. Look how great our study was. This person lost half their body weight, blah, 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 blah.
The only one, but we're not.
I'm like, yeah, this is the one. Results not typical. Like, ridiculous. Anyway, so we've got that. And then we've got most people losing a little bit, a heap of people gaining a little bit, and some people gaining a fair bit. So the waterfall plot looks kind of diagonal. Waterfall plot, if people aren't aware, is where you have each participant, each person gets a line all to themselves. So there's a spine of the chart, a horizontal line, and then starting at the person who lost the most amount of weight, their weight loss is charted like below the line. Everyone gets a line, then you get to 0, and they've kind of got a dot, and then you get lines above the line for people who've gained weight. You can see perfectly what the impact of that program had on everyone in the study. I really like, waterfall plots are awesome. And it makes it then very easy to show people these are the expected outcomes, actually. You could be this person, you could be that person. We don't know. actually. And then but the average of these weight loss trials at that 6 to 12 month mark is like 5% weight loss. And then for the whole group. And then you've got potentially people are still in energy suppression during that time. So their cholesterol levels are being suppressed, their glucose response is nice and high, like nice and sensitive because they're hungry, you know, and the body's looking for glucose. So it's going to respond very quickly when it comes into the system. You've got usually your blood pressure is a little bit suppressed when you're in energy suppression. So your blood pressure looks like it's reduced, even though that's artificially there because of the energy suppression. And so they're like, oh, this is great. Our intervention's fantastic. All it takes is 5% weight loss. But that's not what your data says.
Right.
That's not it. You can't then go out and say, right, you person, you lose 5% and you can have a guaranteed sort of outcome, because that's literally not what their data said at all. So, I mean, that is where we get into the pitfalls of using intervention data to make collective intervention data to make population recommendations that are sort of nonsensical. If you want to say, if the guidelines want to say, right, people need to lose 5% of their body weight, they actually need to test what the impact that advice has on someone, because that's not the intervention that they tested. They tested lose everything that you can, and the average of 100 people will be 5% weight loss. That's what they tested. Didn't test what that actual guideline is. So, and it's similar to the, don't be fat guideline, is based on the observation that smaller people have slightly lower risks than larger bodied people. If they say don't be fat or become smaller if you are fat, that's an intervention. You need to test whether becoming smaller has the effect that you're assuming it does from the observation of these two different stats.
Exactly. Yeah.
It's not a time machine. It's not nothing. Can't wave a wand. It is a thing in itself. Interventional weight loss is an intervention. You're treating it like a medication. Thinking about its treatment burden and thinking about its unintended consequences and its side effects and the risk and benefit analysis, rather than just thinking it's a nothing that will just vanish away stuff.
Right. And that's, I mean, to come back to weight loss surgery, like that's
the whole premise of it.
That is where it's, you know, and there's, you know, they say, oh, well, diabetes is cured. And, but of course it's not really,
no,
many
it's
people become diabetic again, or have higher glucose numbers later on, as they continue to live.
Yes.
But yeah, when you're starving, it looks very different. But there's such a focus on everybody just has to be smaller, no matter how that looks, whether it's, you know, starving, you know, teenagers, like it's going to be happening in your country, to make them lose weight, or, you know, cutting up people's perfectly functional and healthy GI systems and be smaller. But we don't really have, like, from everything you've said and from everything I've read and all the people I've talked to on this podcast, there's just not really any good solid evidence that any of that makes any difference in health in the end, and actually generally makes it worse.
The realities of doing research, in that you typically don't have a ton of time to follow people up. And so the sidestep to that problem is using surrogate markers like biochem values to try to make the claim that if you can modify those values, then that will have an effect on the, like, deathy, diseasey stuff later. That's where we've gotten ourselves pent up, in that we're trying to affect a risk factor and we've got a short period of time to do it. If we looked in the long term, which some studies have done now, we see that trying to modify weight as a risk factor is not really very feasible. It's not really a very reasonable thing to ask a whole chunk of the population to do. And it comes with a significant treatment burden that causes itself negative impact to the people who are doing it.
Mm-hmm.
And so, but if you're only following people for 18 months to 2 years, and that is considered way long term, long term technically in the literature is to the 12-month mark. How 12 months when you're, let's take the fast track trial kids, when you're 15, a 12-month shake diet, starvation plan when you're 15, how that is going to have any impact to when you're in your mid-50s.
Right.
There's a whole heap of stuff in between that has much more influence on your health at 55 than the year that you spent starving in your teen years. And let's face it, lots of us did. I did. You probably did. Like, we're out there already.
Yeah.
How about a retrospective study of people who starved themselves during their teenage years and their health outcomes?
Exactly. And we have even, medical statistics on those people. If you go into any eating disorder treatment center,
Right.
They have so much information. So it's not even just like, oh, I say I didn't eat a lot. No, we have this is what they're eating. This is what they're doing. And then what happened 20 years later, 30 years later, how did it affect their health? If it affected their health. And same with we have, fat kids, right?
Yeah.
If they're just allowed to just say, okay, we're going to let you do what you do and, be who you are and, not change your weight, but just, support health without focusing on the weight change. Again, we have people like that. So,
not enough, but yeah.
Well, I mean, there are a lot of fat kids that we could follow.
Yes.
If we started,
without
we would have
intervening.
To start. Yeah. If that's the problem, is that you would have to, with the larger kids, you would have to almost start now to get a good sample, because the ones that, who are adults now have probably dieted. So you kind of lose that, what happened in the interim, if they weren't, forced to diet. And then with the folks who have had EDs, once they've recovered, you've got some good, good statistics, because you can say, okay, they recovered at this point, and then they were weight stable, and
it's tricky. We would have to make it really valid, it would have to be a big population cohort study, and just follow them, like Framingham or one of those other big studies, because there's just so many variables. But that in itself makes it completely absurd that these researchers asking teenagers would think that it would have an impact. Their justification is, chronic disease risk. That is off the chain. What? We can't really prove it very well in adults.
Right.
As if it's going to make a difference other than stunting these adolescents' growth trajectories and impacting their mental health.
I just did an interview about hypothalamic amenorrhea with Nicole Rinaldi, which will be coming out at some point soon.
Fantastic.
And we were talking about not getting enough food and how it affects bone density in teenagers. And then also talking about birth control in teenagers, but that's kind of beside the point. These kids who are, even for this year, who knows how, that's probably not going to affect them, so they're going to end up with osteoporosis necessarily. But, even that year at 15, how is that affecting their ability to build bone, And for the ones that may continue to starve themselves after the study is over, that is going to affect them long term potentially. There will be, I have no doubt, a percentage that will continue those behaviors.
Oh yeah, absolutely. And you hope that they turn into really staunch Haze advocates when they're recovered from the trauma that they're being put through now. Yeah.
And they wouldn't have to be put through that trauma if this study wasn't happening.
Right.
Yeah, I'd like to get Louise Adams on
You
at
should.
some point to talk
She's
about
one
it.
of my best friends. She's a fantastic gal, and she's very funny. So she would be great to have on.
I listen to her podcast too, and I know she
Yes.
listens to mine too. So, yeah, she definitely is somebody else that I'd like to have on.
Yeah. Well, we are trying really hard to affect the our main research council who gives the power for the more regional ethics committees to approve these things. We're trying to get into the ear of the National Medical Research Council here to try to put in some controls, like at least if you're going to do this population, you at least need to follow them for 5 years minimum, or it doesn't get funded. You know, there are some things, ways that we can, if we can't change the complete paradigm right now, we can help people to see what really happens, to see the kind of experiences that we hear coming out of our clients' mouths, so that that's in the research record, in the academic record here. So yeah, it's hard, but it is the right thing to do.
Yeah, I agree. Well, we probably need to let you go. I really hope that you get some research studies started that are going to be actually super effective and helpful in the future.
I hope so. Well, let me tell you a little, before I go, let me tell you a little about what my big research study, my big PhD research study has found. And so this one was a community adult sample in Australia, so Australian adults, 18 years and over. I managed to get over 3,000 people to participate in my study. And what I did was look at their diet variety, their dietary quality, and I looked at their intuitive eating score, so their dietary restraint, and I looked at whether they were currently dieting for weight loss, or whether they whether they valued weight or healthy habits. Was their main goal and priority goal achieving a healthy weight, is the wording that I use there, or achieving healthy habits. So we've sort of got outcome goal versus process goal.
Okay.
And so that's how I categorized them. And I found very clearly, like shockingly clearly, that whenever there is weight control in the equation, so either they prioritized attaining a healthy weight as their main priority goal, or they were currently actively weight loss dieting, that impacted on their mental health and their diet quality. They're more likely to have a narrow diet. They're more likely to be a more restrained, so like less flexible eaters. They're more likely to have extreme weight control behaviors, poor body image, poor level of self-compassion, poor level of body appreciation. So all of these indicators of overall well-being were like horrifyingly impacted by any suggestion that weight control was an important thing for them. Looking at health-focused size acceptance categories, so people who are not dieting and who indicated that their main sort of goal in terms of lifestyle was attaining healthy habits rather than anything to do with weight. Those people, and thankfully, like I managed to get 900 people that fitted that description. I was amazed, because here, you know, it's like, it's pretty easy when you're stuck in diet culture media all the time to assume that that people are sort of doing what they're told and trying to diet. But anyway, I found these, 900, they're not unicorns, but real people who have accepted their size and who are working on attaining a lifestyle where healthy habits are what drives them. Right. And I found that their diet quality was much broader than the dieters. And I found that their mental health was much better than the dieters. And they're like vanishingly smaller risk of eating disorder behavior or eating disorder risk in the screening tools. So everything is pointing in a dietetics way. As a dietitian, I value dietary quality. It's a no-brainer that health-focused size acceptance is superior a manner to achieve dietary variety than dieting is. So I'm super pumped that that was what my research was. I was happy for it to find equivalence, you know, because what's said about Haze all the time is that, oh, well, if you accept yourself, you'll just eat junk all day.
Right.
That's what the perception is. It's one of the criticisms, the assumed criticisms of this field. That's not what I had seen personally,
right.
but I wanted to see, but I wanted to see for real, like, what is the deal? That's why I did the research, and I was happy to accept whatever came out of the data. You have to do that as a researcher. And I was expecting equivalence. I was not expecting this, that, you know, that things would be very different, and they are. Well, they were in my sample of 3,000. It's not representative, but there's a whole chunk of humanity. And I had people in there who were 18, and I had 70-year-olds in there, and I had a good number from all of different age groups and minority backgrounds, and, you know, so it's a nice sample, and to be able to have that finding is thrilling.
Yeah,
Can't wait for it to get published.
That reminds me of Linda Bacon and Lucy Affermore's study, you know, and it was much smaller, and they were focused on, you know, they did do you know, checking blood pressure and and all that kind of stuff, and they did weigh people. So but it was split between we're doing this intervention for weight loss reasons.
Yes.
So there was a focus on like lose weight loss. Let's lose weight loss. And Haze and health oriented interventions where, like, we're worried about weight loss. We're actually just like, what can you do to
size acceptance?
Health? So they're actually like imposing what you are seeing naturally. But in a smaller group. But what I always thought was so interesting about it was, I mean, in the end, the weight was negligible. I mean, the weight loss was negligible in both groups. So what does it even matter? And then all of the other categories that they looked into, you know, like blood pressure and glucose and stuff, the Haze group actually did well in there, and then continued to do so after 2 years, because theirs was also only 2 years. And the other group did really great initially, and then their quality went down.
That's it. The Haze changes are really sticky.
So those folks were still doing a lot of the things that they had started out doing, and then I looked at the attrition rates too, and with the Haze group, there was like 8% left. Like, which is, from most of the things I've read, I mean, most of the studies I've read, and I haven't read nearly as many as you have, like 8% is so small for
you expect 20
weight loss study. And then the weight loss side, I don't remember what the percentage was, but it was a considerably larger percentage. Probably potentially because they gained weight, but I don't know for sure. And so so I'm really glad that you're doing this study, because it sounds like it's sort of on a larger scale. It's that study or supporting that
right
study,
it's another chunk of the bridge platform in this field, because we've got these intervention studies, and we've now got 5 systematic reviews of Haze informed interventions, 13 randomized controlled trials at least that we know about. And so we can't, you know, people can't claim that there's no research anymore. There certainly is in group-based intervention research. We've got a good body of evidence to be fairly certain that it's not detrimental to the health of participants who choose to undertake this.
Which is certainly a big thing, you know.
Yeah, it's huge. So that's like, we know about.
Let's see what happens.
Right. We know about the harms. And certainly you can't make someone who's really stuck in diet brain into a Haze person with the click of a finger. That doesn't happen. But if somebody has the proclivity to want to take this different approach, the outcomes are wonderful. And the harms are minimal. So we know that for sure. But what we didn't know before now really is whether having a size acceptance outlook, general life outlook, made any difference versus the weight control outlook in the population. So people who are non-intervention people. And now we know that. So that means that the likelihood that public health messages that are size affirming are likely to be good for both weight-centric people and size acceptors. And so the harm involved is much lower than with a weight-centric public health message. So this is the thread through my thesis and through my papers, that the evidence now is clear that this is not harmful, and it should be something that's trialed and tested on a larger scale to see if it works. We've got that step now. This now supports further public health messaging that's size affirming.
I would love to see a study, and I don't know if we can do it yet, but to see a study where you look at the outcomes for healthcare professionals whose patients have, whose provider is a
case provider,
is affirming as opposed to weight centric, and then those results of those patients, like how do they fare. I mean, that would be a huge study, but
it's tricky. I had a 6-month study as part of the PhD. I recruited a whole bunch of dietitians, Hayes dietitians and weight loss dietitians. And then the study design was then that their clients would be enrolled. So at their first appointment, they would pitch the research to their clients and invite them to be part of the study. And then I had nothing to do with the dietitian after that. The client would participate and I would contact the client. Mm-hmm. And so I had 70 dietitians as like recruiters, but the participants, the patients, didn't enroll themselves at the rate that I had hoped that they would. So unfortunately, I didn't get the numbers that would mean that I've got any sort of statistical validity. I mean, I will be describing them, but I can't say for certain. So I did try that, but the trouble is recruitment. So again, it's the practicalities of doing the research that are tricky. And so I think once the PhD is done and I've got myself a permanent position at a university that has a health service attached, I'll be able to do a proper cohort study of clients. Yeah, that's my evil plan. But that's my research vision, is to be able to fill that gap as well, where because people who visit university-based health services understand that it's a low-cost service because it's involved in research. And so we'll be able to get that up much more readily than private practice providers, which is who I was using as my recruiters in that other study.
Well, I can't wait to see what you come up with in the future. And I can't wait to see this study too. I think it's going to be amazing once you birth this baby.
Right.
Your last one.
Yes.
It's probably easier to birth the human ones.
Yeah, because their timelines, I don't have anything, I'm not involved. They do the thing.
They're out, and then there you are.
Every contraction I have to do, so it's definitely harder.
But it was so amazing to talk to you, and hopefully we'll get to talk about some other things. I still have things on my list, so.
Thanks so much for having me on.
Fascinating. So yeah, and I will put up whatever you want on the show notes as far as like contacts. But do you have anything that you want to just let people know how to find you online?
Sure. So if you're a health professional and you're after professional development in Hayes-informed approaches, the non-diet approach, or weight science, you can go to www.healthnotdiets.com. And if you're interested in accessing my podcast or the course that I have with this content, which is called Unpacking Weight Science, that's at www.unpackingweightscience.com. You can also probably find everything if you just Google my name, Fiona Willer. So yeah.
Fantastic. And I really do recommend your podcast to everybody. It's fantastic.
Thank you.
Fantastic. I'm going to have to join the Patreon now to get all the other episodes. I just found out about that like a week ago. So I was like, what? There are more? Because I love all the ones you've done so far. So
thanks.
So yeah, thank you so much for coming.
Thank you for joining us today. The theme music was composed and performed by Galen Davis. Cover art was designed by Stacey Bias. Administrative support was provided by Paige Carlson. If you enjoyed the podcast or learned something new, please subscribe as it helps amplify this important message.